Hello, everyone. Welcome to our Zoom meeting. I'm going to hand it to uh, Dr. Namariq and her team. Please take it from here. Thank you.
Thank you, Dr. Nader. Good morning, good evening, and good afternoon, everyone, whatever you are, whatever your time zone. Thank you for all for being here today. I hope you're all doing well. I'm excited to kick off this meeting. My name is Namariq Al-Naim, and I'm honored to be mentoring today's meeting, which will be conducted by the Canary team and moderated by the Canary team leader, Dr. Huyam Elsir. There are going to be multiple presentation about wide variety of topics. Later, there are going to be mock interview. And at the end, we're going to open the floor for questions, discussions, and exchanging experiences. So without further ado, let's get started. Dr. Huyam, are you ready?
Thank you, Dr. Namariq. I'm ready.
All right,
Hello,
the floor is
everyone.
yours. You can start.
Thank you. Thank you, Dr. Nader, for this great opportunity. Thank you, Dr. Namariq, for supporting me. My name is Huyam Elsir. I am leader of Canary Group. Here we are agenda for this meeting. There is a 5. First one is a preoperative management of the geriatric patient. The second one is NIH stroke score.
Dr. Huyam,
yeah.
are you sharing the agenda?
No, I will say it.
Okay, I can help you.
Yeah.
I can help you with sharing the agenda. No worries. You can go ahead.
Okay. There are the agenda of this meeting. Number 1 is a preoperative management of geriatric patient. That will be presented by me and Dr. Asna, Dr. Sultan, Dr. Abeer, and Dr. Ibtihal. The second one is NIH stroke score, which will be presented by Dr. Nadine and Nidhal. The third one is how to make scatter plateau with a trend line in Excel, which can be presented by Dr. Syeda. The fourth one is aldosterone dysregulation and its role in primary hypertension, which will be presented by Dr. Mohamed, and will be ended by mock interview that could be presented or modulated by Dr. Rufayda and Dr. Riham and Zainab. Will be begin with the first one. It's a preoperative care. By the end of this presentation, you can be able to describe how age-related physiologic change influence preoperative care, risk factors of cardiovascular, pulmonary, renal, and neurologic complications, elements of preoperative management of select medical problems, and how to avoid iatrogenic complications. We will be covered these topics: overview of operative therapy for older people, surgical decision-making, preoperative assessment and management, preoperative and postoperative management of selected medical problems. Surgery is a common treatment for older patients. More than 55% of all surgery are done on patients 65 years old or older. And there are many advancements in the surgical technique and anesthesia that can lower the surgical risk and shift the risk-benefit ratio to a favorable surgery in increasingly older patients with a more complex conditions. While surgery per se is a safer, older adults experience a disproportionate majority of postoperative morbidity and mortality due to postoperative infections or cardiac events. Okay, age-related changes influence preoperative care. As a result of normal aging, multiple organ systems may have a limited physiological reserve. For example, stiffness of the cardiac and blood vessels, which can lead to complicated fluid management. Also, decreased thermoregulation that can lead to increased risk of preoperative hypothermia. Adding to stiffness of the thoracic cage and decreased ciliary function that can lead to decrease the pulmonary reserve. Also, aging can cause altered body composition, decrease kidney function, hepatic blood flow, hepatic enzyme activity. All this can lead to change in the pharmacokinetic of drugs. We can move. Preoperative care should be individualized. Not all organ systems age at the same rate, even within an individual. Most older people have one or more chronic conditions that influence preoperative care, either directly or through the drug that they use. Thus, older patients require thought and individualized preoperative care and often benefit for a multidisciplinary approach. Surgical decision-making, according to geriatric provider, should assist in the process of deciding on surgery. Also, patient's goal of care should be elicited, and the surgical consultation should be proceed only if the consistent with the patient-oriented goal. Thank you. If there is any question, you can tab it on the chat box, okay? Now we are moving to Dr. Sultan. Are you ready, Dr. Sultan?
Yes, I'm ready. Thank you for this opportunity. I'm Dr. Sultan Ahmed. I'll be speaking about perioperative assessments of cardiovascular systems. Well, the risk of postoperative cardiac events is directly related to age. There are many calculated cardiac risk scores, such as the American Society of Anesthesia Classifications, the American College of Cardiology, American Heart Association guidelines. The most important risk factor is the age in all of these scores. Regarding the perioperative cardiac risk assessments, you have to keep in your mind just these 5 questions. It's a very simple diagram. The first question is the surgery an emergency surgery? If the answer for that question is yes, then you go directly proceed to the surgery. No need for any perioperative cardiac assessments. If the answer is no, so the surgery is not emergency surgery, then you're going to ask the second question, which is there any of the following major risk factor present? Is the patient having unstable angina, myocardial infarctions within the past 6 months, decompensated heart failure, moderate or severe valvular moderate or severe valvular disease, or if the patient is having dyspnea. If the answer is yes, then cancel the procedures or postpone the surgery and correct the acute cardiac conditions, reassess the valvular functions with echo, and address the dyspnea. If the answer for that question was no, then you proceed for the third questions, which is the procedure is a low-risk procedure such as cataract, endoscopy, breast or plastic, or superficial surgery. If it is just a low-risk surgery, then yes, proceed for the surgery. Still, there is no need for any cardiac risk assessments. If the answer was no, then you go to the fourth question, which is the patient able to do heavy housework, perform yard work, climb a flight of steps, walk up a hill, or run a short distance? In total, we just need to make sure that the patient is able to do about 4 minutes. Another simple question, you can just ask the patient if he can carry a grocery bag and climb 2 flights of stairs with that one. If the answer is yes, then you proceed to the surgery. If the answer is no, then you go to the fifth and last questions. Is the patient is medically appropriate and willing to undergo testing for cardiac ischemia or revascularization before surgery? Will further information on cardiac risk impact decision to proceed with surgery or perioperative care? If the answer is no to either, then again, discuss potential risk and benefits of surgery with surgeons and patient to decide whether or not to proceed with surgery. And if the answer is yes to any of these, calculate the risk, consider performing cardiac stress testing such as pharmacological or exercise stress testing. And if abnormal, you can proceed for revascularization such as CABG or BCI. Next. Perioperative care, cardiovascular risks, cardiovascular systems. Well, as usual, we start with history and physical examination. Supplemental cardiac testing only useful in following specific circumstances. For pre-op ECG useful as baseline in patient with heart disease undergoing a non-low risk surgery, moderate or high risk surgeries. In patient with dyspnea of uncertain causes, consider measurement of LV functions. In patients with moderate or worse valvular stenosis or regurgitations, check pre-op echo if none done in the past year. Next. Major indication for revascularization in the perioperative periods are significant unprotected left main vessel disease or 3-vessel disease or 2-vessel disease, which include proximal LAD. And last is survivor of sudden cardiac death with presumed ischemic ventricular tachycardia. Certain medication given before or after surgery can reduce cardiac and vascular complications of surgery, such as beta blockers, statins, which should be given like more than 48 hours before the surgery. Next. Cessations of anticoagulation before surgery in older patients. Weigh the protective benefits versus bleeding risk in patients already on anticoagulation. Do not withhold for cutaneous surgery, dental extraction, minor or oral procedures, cataract surgery. For other procedures, cessations of warfarin with or without low molecular weight heparin bridge therapy is based on patient risk and thromboembolisms. And most of the hospitals, they have their own guidelines regarding this. Management of patients with coronary stents. Cohort studies identified substantial increased risk of major adverse cardiac event when surgery is performed soon after coronary stent is placed. Optimal timing for elective surgery, not before 30 days after a parameter stent, which is not used frequently anymore, and not before 365 days after a drug-eluting stents. There are some exceptions for that. Next. Next. Hello?
Dr. Huyam, actually the screen froze. I'm just trying to fix it, please.
Okay.
Dr. Huyam, are you here?
Yeah, I'm here.
Okay, the screen is freezing, so
Dr. Asna, it share the screen. Just give her seconds
all
to
right,
fix
sure.
it.
So I'm unable to fix it, Dr. Huyam. I think I'll have to log in again. I'm sorry
Thank
for
you.
that.
Thank you.
Dr. Huyam, you can share the screen for Dr. Sultan while Dr. Asna figure out the issue.
Okay. Is it clear?
No.
Try to unshare and share it again.
Can I share it?
Yeah, sure.
Can you
Go
see
ahead. Are you sharing your screen, Dr. Sultan, right now?
it? Yes. Can you
Okay,
see?
we see the screen. Yes, we do. Try to move it.
Yeah.
It's not moving.
Is it moving now?
Yeah.
No.
It moved.
Yeah, it moved. Yeah, good. Go ahead.
Okay. So, perioperative risk assessment in respiratory systems. Major risk factors for pulmonary complications. They divided into patient-related or procedure-related. Regarding the patient-related, it's include age, COPD, American Society of Anesthesia Class 2 or greater, heart failure, ADL deficits, low albumins. Procedure-related, including emergency surgery, prolonged surgery, which is more than 3 hours, abdominal aortic aneurysm repair, neurosurgery or thoracic, abdominal, head and neck or vascular surgery. General anesthesia is also a risk factor. That's conclude my presentation. Thank you for listening.
Thank you, Dr. Sultan, for nice presentation. And now, Dr. Asna, are you ready?
Yes, Dr. Huyam.
Okay, go ahead.
All right. So good evening, everyone. I'm Dr. Syeda Asna, and I'm extremely sorry for the delay. So continuing with what Dr. Ahmed just now went about, the 2007 ACP guideline, according to the 2007 American College of Physicians Guideline for Risk Assessment and Perioperative Management of Pulmonary Complications, we need to appraise the risk factors. We need to undergo routine chest X-rays that are not recommended except for known cardiac or pulmonary disease in patients undergoing thoracic, upper abdominal, or AAA surgery. Spirometry is recommended for patients suspected of but not yet diagnosed with COPD, so that COPD managements can be started as appropriate. Spirometry is also indicated for patients who are undergoing lung reduction surgery. Post-op lung expansion therapy is recommended. So the next parameter that we look for as a preoperative assessment is the kidney function. Accurate estimation of GFR is important. Renal and glomerular blood flow decreases with age and muscle mass declines. So serum creatinine may appear normal even when kidney function is not. The GFR can be estimated by calculating the creatinine clearance using either the Cockcroft-Gault equation or by relying on the modification of diet and renal disease study, the MDRD method, that some laboratories automatically report. And regarding the Cockcroft-Gault equation, it is usually measured as 140 minus the age into the ideal body weight divided by 72 into serum creatinine. The entire fraction is multiplied by 0.85 in females. The next thing is many drugs used perioperatively may require dosage adjustment if renal function is impaired. For example, patients taking digoxin or lithium or allopurinol, they require renal dose adjustment. Next thing is the risk of delirium. The preoperative risk factors in non-cardiac surgery are age greater than or equal to 70 years, cognitive impairment, limited physical function, history of alcohol abuse, abnormal serum sodium, potassium or glucose, intrathoracic surgery, abdominal aneurysm surgery. The most important intraoperative risk factor for delirium is blood loss. Next thing is functional status and triality. Patients who require help with the instrumental activities of daily living and activities of daily living are at risk of poorer surgical outcomes. For those who are new with this terminology, activities of daily living are those activities which are necessary for basic self-care and functional living, like feeding, washing, and eating, whereas the instrumental activities of daily living are those complex tasks which may not be essential for the functional living, but they improve one's quality of life. For example, meal preparation, housekeeping. Next, disloyalty has been associated with a 3 to 13-fold increase in being discharged to a nursing facility rather than home, and higher rates of delirium, cognitive impairment, and functional decline and death has been noted. It is important for patients and family members to understand the risks associated with frailty or poorer functional status when considering surgery, and to consider whether alternatives may be appropriate depending on a patient's goals of care. Avoiding iatrogenic complications, encourage time out of bed and avoid restraints. Early consultation of a physical and occupational therapist may be reasonable. Remove indwelling catheters as soon as possible to reduce the risk of infection and the effects of restricted mobility. Stop IV fluids and lift restrictions on diet as soon as possible. Review medications regularly. Thank you so much, and I'll be followed by Dr. Ibtihal.
Thank you, Dr. Asna, for nice presentation. Now, Dr. Abeer, we will continue. Are you ready, Dr. Abeer?
Yes, I'm here.
Yeah. Go ahead if you're ready.
Sorry, but I'm starting off with kidney damage, not hypertension. I think this is still
Dr. Asna?
Dr. Asna's, part.
Yeah. Dr. Asna?
Yes, please.
You have
regarding the next parameter, that is for post-operative care, we have to look into hypertension. So we're supposed to search for non-cardiovascular causes such as pain or urinary detention. We have to assess volume status, review fluid administration, and notice whether antihypertensives were omitted or not. Consider a parenteral antihypertensive for treating uncontrolled essential hypertension while NPO. And topical agents such as topical nitroglycerin may also be useful post-operatively if patient is unable to take oral medications. Dr. Ahmed.
Okay, thank you very much. Now, Dr. Abeer.
Dr. Riham, I'll just continue till a few more slides, please.
Okay.
The next thing is regarding supraventricular tachycardia. We have to look for that post-operatively. These are usually associated with a history of prior supraventricular dysarrhythmias, asthma, heart failure, or premature atrial complexes on a preoperative ECG. More common in patients who've had vascular, abdominal, or thoracic procedures. Attempt to restore sinus rhythm or at least control the ventricular rate by infusing adenosine, a beta blocker, or a calcium channel blocker. Dr. Ahmed. Next thing is to look for atrial fibrillation. Attempt conversion to sinus rhythm with electrical cardioversion or infusion of amiodarone if poorly tolerated and risk of thromboembolism is low. Spontaneous reversion to sinus rhythm often occurs within 6 weeks after surgery. Persistent AFib beyond the 24 to 48 hours increases the risk of thromboembolism. So consider anticoagulation to reduce the risk of stroke. Next thing, the next parameter that we're looking for is heart failure. May develop as a result of excessive fluid administration, new cardiac ischemia or arrhythmias. It can be extremely challenging to ensure optimal ventricular filling pressures by basing the assessment of volume status on physical examination and standard laboratory parameters alone. Pulmonary artery catheters have been recommended for high-risk patients, but studies have not shown a mortality benefit, and most authorities advise against this approach. Thank you so much.
Thank you, Dr. Asna, for great presentation. Now we are go ahead for Dr. Abeer.
Okay, thank you, Dr. Asna, for your presentation. So hello, everyone. My name is Abeer Ahmed, and I will continue with the post-operative care. So first off, we'll start with kidney damage. We need to be able to recognize the early signs of post-operative kidney damage, which include oliguria, which means low urine output, isosphenuria, which is when the urine concentration is equal to that of the plasma, and an increase in serum creatinine. These signs are very important because they help us detect kidney issues early on. When it comes to the mechanisms of post-operative kidney damage, there are several, one of which includes impaired renal blood flow, and it is signaled by a urine sodium less than 40 milliequivalents, along with a urine to plasma creatinine ratio of greater than 10:1. In contrast, we have acute tubular necrosis, which is marked by urine sodium level higher than 40 milliequivalents per liter, with a urine to plasma creatinine ratio less than 10:1. Additionally, we may also see granular or epithelial silicates in the urine sediment. We also have obstructive nephropathy, which is especially seen in men with prostatic hyperplasia, clinically seen as distended palpable bladder. So for patients with acute tubular necrosis, it's very important to hold all potentially nephrotoxic medications and maintain a euvolemic state. For those with obstructive nephropathy, inserting a bladder catheter can help reduce the risk of hydronephrosis and impaired kidney function. So moving on to the gastrointestinal concerns, there are many gastrointestinal issues which are quite common after surgery, which include constipation area. For those with constipation, it's advisable to order a laxative and a stool softener whenever an opioid analgesic is used. Dietary suggestions such as prune juice, and applesauce and brain are also very recommended. Prune is the dried plums, and these are all known for their high fiber content, which are used as a natural remedy for constipation. For those with diarrhea, it's important to check manually for fecal impaction and consider having a stool specimen checked for leukocytes or Clostridium difficile toxin. It's also very important to focus carefully on the volume of resuscitation and treating the underlying cause. For patients with type 2 diabetes, oral drugs are usually held at the day of the surgery, especially metformin, which theoretically may increase the risk of metabolic acidosis during times of stress. One option for managing glucose during periods of prolonged fasting is administering an IV glucose-containing solution at a constant rate while closely monitoring blood glucose by finger test assay and administering a subcutaneous insulin as needed to avoid hyperglycemia until the patient can further resume eating. Many type 2 diabetic patients who will be fasting for less than a day can be safely managed by only withholding long-acting diabetic agents and treating the hyperglycemia with short-acting insulin alone. Vigilance is very important, especially for diabetic patients, as there are substantially increased risks for both hyper and hypoglycemia in the perioperative time. Patients with type 2 diabetes who use insulin should follow the following protocols. At the day of the surgery, they should hold the outpatient dose of insulin and give a sliding scale if insulin is needed. A sliding scale is basically when you adjust the insulin dose based on the patient's current blood glucose readings. Then on the first day of eating by mouth, a general rule is to give half the outpatient dose of diabetic drugs with sliding scale insulin is needed. And then later, when the person can consume a usual diet, we continue full doses of diabetic drugs. In terms of patients who are on corticosteroids, preoperative administration of stress doses of steroids is appropriate for patients on prednisone more than 20 milligrams per day for more than 1 week, or those with known adrenal insufficiency. When the hypopituitary axis function is in question, it's very important to measure the cortisol. And then when the cortisol is elevated, we consider a 30-minute ACTH stimulation test. For patients, for reducing the risk of delirium, patients with preoperative delirium risks, clinicians should be especially vigilant about reducing sleep interruptions, avoiding dehydration, encouraging mobility and avoiding restraints, enhancing sensory input, minimizing medications, controlling pain and constipation, as well as correcting electrolyte abnormalities. Finally, it's very important to differentiate between delirium and post-operative cognitive dysfunction, which is basically a syndrome characterized by abnormalities in learning and memory. It's most commonly seen in patients after cardiac surgery, and it persists for many months in 10 to 30% of patients. Interestingly, there is no demonstrated link to hypotension, hypoxemia, or any type of anesthesia used, and the treatment is just supportive. Thank you. This marks the end of my presentation. Dr. Ibtihal will now take over and continue with the rest of the post-operative care. Thank you guys for listening.
Thank you very much.
Hello.
Doctor.
Thank you, Dr. Abeer. Hi, everyone. My name is Ibtihal. Today, I will be discussing the importance of post-operative care, especially for older adults after surgery. Managing pain and recovery is crucial to avoid complication. Proper post-operative care is not only ensure the patient comfort, but also help in reducing risk like infections, dependency on medication, and prolonged hospital staying. Can you change the slide, please? Oh, okay, it's the first slide. Thank you. Throughout the presentation, I will cover the key recommendation for effective post-operative care, case study, and the way to manage pain safely and efficiently after surgery. Let's start by monitor pain level. One of the primary focuses in post-operative care is monitoring and managing pain level. Effectively, the oldest the oldest and cognitively impaired patients are at the highest risk for undertreatment of pain. Therefore, regular assessment should be conducted to understand the patient pain experience. Utilize opioid. Most post-surgical pain requires opioid analgesia. However, for cognitive intact patient, we can consider using patient-controlled analgesia pumps. This approach allows patients to manage their own pain relief, which can improve satisfaction and reduce reliance on high dose of opioids. Prevent constipation from opioid. It's important to note that opioid analgesic may cause constipation. To counteract this, we use laxative and stool softeners the use of laxative and stool softeners should generally be advised alongside opioid treatment. We should describe the lowest effective dose. As with any older patient, opioid should be used at the lowest effective dose for the shortest time necessary. This strategy helps to reduce the risks associated with long-term opioid use, including dependency and adverse effects. Patient discharge and education. Patient discharged home on opioid analgesia should receive prescription for naloxone and emergency treatment for opioid overdose. Education on how and when to use it is essential for safety. Let's discuss some case study about pain management. Recommendation firstly. Don't perform stress cardiac imaging or advanced non-invasive imaging as a preoperative assessment. I think there's some issue with the slides. Don't perform stress cardiac imaging or advanced non-invasive imaging as preoperative assessment in patients scheduled to undergo low-risk non-cardiac surgery. Patients who have no cardiac history and good functional status do not require preoperative stress testing before non-cardiac thoracic surgery. Don't perform preoperative medical testing for eye surgery unless there are a specific medical indication. Avoid echocardiogram for preoperative and perioperative assessment for patients with no history or symptom of heart disease. Next. Don't order coronary artery calcium scoring for preoperative evaluation for any surgery irrespective of patient risk. Don't initiate routine evaluation for carotid artery disease before cardiac surgery in the absence of symptoms or other high-risk criteria. Before cardiac surgeries, there is no need for pulmonary function tests in the absence of respiratory symptoms. Don't obtain preoperative chest radiography in absence of clinical suspicion of intrathoracic pathology. We will continue with the case studies. Okay, in summary, there's some issue with slides. In summary, effective post-operative care is critical for ensure patient comfort and safety. By monitoring pain level, using opioid, and employing preventive measure against common complication, we can enhance recovery outcome for elder adults. case. And we go to the case, please. Next slide. Okay, our first case study. A 78 years old man come to the office for preoperative assessment. He is scheduled for total hip arthroplasty for sharp, severe, non-radiating pain in his left hip. He has stopped walking because of the pain and depend on his wife for meal preparation and most household chores. He has a history of hypertension, diabetes mellitus, and chronic kidney disease and osteoarthritis. He is on insulin, atorvastatin, acetaminophen as needed for pain. Next slide. On examination, active range of motion of the left hip is limited by pain. ECG show normal sinus rhythm and Q waves in lead 2, 3, and AVF. Laboratory finding PUN 38 milligram per deciliter. Creatinine 2.1 milligram per deciliter. Hemoglobin A1C 7.4%. In this case, standing order, which one of the following the most appropriate next step? A. Coronary angiography. B. Exercise treadmill test. C. Pharmacologic stress test with imaging. D. None further test is necessary. In this test, in this case, standing order we put in place of narcotic analgesics with a clear guideline on when to withhold medication. The nursing staff was instructed to assess her pain regularly, to use non-pharmacological methods such as ice pack and physical therapy to aid her recovery. So the correct answer is anyone want to answer? Okay. Okay, the correct answer is C. Can we move to the next case? A 72 years old woman with pancreatic cancer undergo resection with Whipple procedure. Surgery is uneventful, but her mental status changes abruptly the first day after the procedure. She's awake, combative, and agitated. She's believed that she's at home and that her daughter is holding her against her will. The nurse report that she has had 2 such episodes in the post-operative period. On examination, her blood pressure is 112/80. Heart rate is 106 beat per minute. She's disoriented. Abdominal incision is not erythematous or tender. The remainder of examination is unremarkable. Which one of the following is the most appropriate next step? Does anyone want to answer the question?
I guess it's to go for neurological consultation.
No. The correct answer is A. Obtain electrocardiography and measure cardiac biomarker. Okay, can we move to the next case? A 67 years old man come to the office for perioperative assessment before the elective resection of parotid adenoma, scheduled to take place in 2 weeks. Other than the facial swelling, he feels well and has no major symptom. He has a history of diabetes mellitus, hypertension, chronic atrial fibrillation. He's on medication of amlodipine, apixaban, metformin. Which one of the following is the best approach to managing the anticoagulation preoperatively? A. Stop apixaban 2 days before surgery. B. Stop apixaban 2 days before surgery, bridge with low molecular weight heparin. C. Stop apixaban 2 days before surgery, bridge with unfractionated heparin. D. Continue apixaban. The right answer is stop apixaban 2 days before the surgery. Okay, thank you everyone for listening. If you have any question, you can add it in group chat.
Thank you, Dr. Ibtihal, for nice presentation. If there is any question, you can type in the chat box.
Thank
now
you all for thank you all for the great presentation and very well put together one for a very critical and very important topic. The perioperative management in geriatrics is crucial because, it includes the assessment of different organ functions, the assessment of cardiac risk scores, the kidney function, the medication management, and management of pain and other comorbidities. I hope today's presentation will help all of us in providing a high quality care in our daily practice. So thank you so much. And if you have any question, please go forward. If there are no questions, we can move to the next topic. Dr. Huyam.
Yeah. Now we are going with Dr. Nadine and Dr. Nidhal for the next presentation.
Good evening, everyone. I'm Dr. Nadine. I'm going to be talking about the NIH stroke scale. I'll be sharing my screen right now. Is it clear?
Yeah, it's clear.
Okay, so first of all, before talking about the scoring system itself, there are a couple of instructions that we need to talk about. First one, administer stroke scale items in the order listed that we're going to talk about. You need to record the performance in each category after each subscale exam. You can't go back and change the score. You need to follow the direction provided for each exam technique. Scores should reflect what the patient does and not what the clinician thinks that the patient can do. The clinician should record answers while administering the exam and work quickly at the same time. Except when indicated, the patient should not be coached. Repeated requests to the patient to make special efforts. So, talking about the stroke scoring, there are multiple items on this score, the NIH stroke scale. And the lower the patient score on each item, the better. So there are a range of scores from 0 to 3. The lower, the better. The total of the amount of score is 42, which is a very severe disability. And it is subdivided into multiple items that needs to be examined. First one is the level of consciousness, which is subdivided into 1A, 1B, and 1C. 1A being the level of consciousness when the physician enters the room and he sees the patient. Is the patient alert and responsive? If yes, he gets 0. If not alert but arousable by minor stimulation to obey, answer, and respond, he gets 1 point. He gets 2 points when he's not alert and requires repetitive stimulation to attend, or is obtunded and requires strong or painful stimulation to make movements. He gets 2 points. 3 points if the patient is areflexic or totally unresponsive or flaccid. 1B is the level of consciousness, but you ask the patient 2 questions here. You ask what month it is, and you ask about their age. If the patient answers both questions correctly, he gets 0. He gets 1 point if he answers one question correctly, and 2 points if he answers neither of the questions correctly. Patients who are unable to speak because of endotracheal intubation or tracheal trauma or severe dysarthria from any cause or language barriers, they get a score of 1. And the initial answer is the one that needs to be recorded. Moving on to 1C, which is level of consciousness on command. Here you ask the patient to open and close their eyes, and then to grip and release the non-paretic hand. Substitute to another one-step command if the hand cannot be used. So if the patient performs both tasks correctly, he gets 0 points. He gets 1 if he performs one task correctly, and he gets 2 points if he performs neither of the tasks correctly. Patients with trauma, amputation, or other physical impediments should be given suitable one-step command. Only the first attempt is being scored. Second item being tested is the best gaze. Here, only the horizontal eye movement will be tested. Voluntary or reflexive oculocephalic eye movement will be scored, but caloric testing is not done. If the patient has conjugate deviation of the eye that can be overcome by voluntary or reflexive activity, the score will be 1. If a patient has an isolated peripheral nerve paresis, he scores a 1. Gaze is testable in all aphasic patients. Patients with ocular trauma, bandages, or pre-existing blindness or other disorder of visual acuity or fields should be tested with reflexive movements and a choice made by the investigator. So he gets 0 points if the best gaze was normal. He gets 1 point if there's partial gaze palsy. Gaze is abnormal in one or both eyes, but forced deviation or total gaze paresis is not present. He gets 2 points if forced deviation or total gaze paresis is not overcome by oculocephalic maneuver. Third item is the visual. Visual fields, upper and lower quadrants, are tested by confrontation, using finger counting or visual threats. As appropriate, patient may be encouraged, but if they look at the side of the moving fingers appropriately, this can be scored as normal. If there's unilateral blindness or inoculation, visual fields in the remaining eye are scored and score 1 only if there's a clear-cut asymmetry, including quadrantopia, if is found. So if the patient is blind from any cause, scores 3. Double simultaneous stimulation is performed at this point. If there's extensions, patients receive a 1, and the results are used to respond to item 11. So if he gets, there's no visual loss, he gets 0. Partial hemianopia 1, and complete hemianopia, he gets 2 points. Bilateral hemianopia, 3 points. Number 4 is the facial palsy. You ask or use pantomime to encourage the patient to show teeth or raise eyebrows and close eyes to test for facial palsy. You score the symmetry or grimace in response to nauseous stimuli in the poorly responsive or non-comprehending patients. He gets 0 points if there's normal symmetrical movements. 1 for minor paralysis, flattened nasolabial fold, and asymmetrical on smiling. He gets 2 points if there's partial paralysis, total or near total paralysis of the lower face. He gets 3 points if there's a complete paralysis in one or both sides, absence of facial movement in the upper and lower face. This is the end of my part. Now Dr. Nidhal will carry on from here.
Thank you, Dr. Nadine, for nice presentation.
Thank you.
Hello, everybody. I will continue talking about the NIHSS. So the sixth variable that we are assessing is the motor leg, which is, it is the motor. Like we are assessing the motor for both the arm and for the leg, and both of them, they are looking similar to each other's. So 0, whenever we are starting this, we are asking the patient, even if he is standing or if he is lying on the bed. If he's standing, we ask him to keep his limbs hold in 90 degrees, while if he's lying down, we ask him to keep it in 45 degrees. So this degrees is different according to the position of the patient. And then we are going to count for 10 seconds. Or we are going to wait for 10 seconds. So while he is holding his arms straight forward on him, and we are going to see and we are assess. So if the patient, he keep holding his limb for 10 seconds, then this is 0. But if there is any drift, then this is at one of the limbs. Then the drifting means that the patient can't hold his arm like straight forward, and like sometimes it may fall down. So if there is any drift, any kind of the drift, this is 1. Okay, if for 2, you will find that the patient is, whenever he's trying to keep his arms in front of him, you will find that it's fall down. So he need to do effort against gravity. While there is no effort at all, and from the beginning, you are letting him to keep his arms just in front of him, and immediately he fell, like the both limbs, they are falling down. So this is 3. Here is going to be 3. Why the patient, if he can't move at all, this is 4. We are counting it as 4. Sometimes you will find the patient, there is some kind of joint fusion, or there is kind of amputation. So you can't assess it, and at the same time you can't put like a score without assessing the patient. That's why you are gonna write UN. UN means like untestable. This for the motor arm. The same thing, we will find that this is similar to the motor leg. Like with the same thing, we will ask the patient either if he is sitting, if he is in a sitting position, we'd ask him to keep or hold his leg for 90 degrees. But if he's lying down, we'd ask him to hold his leg for 30 degrees. And again, we are gonna wait for full seconds this time, not 10 seconds, and we will see if there is any kind of drift and any leg, this will be counted as 1. If there is the same thing, if the patient need to make an effort and he can keep his limb like get hold for a very long time, then we will count this as 2. If there is no, like, immediately the leg will fall down, this means it's going to be 3. If there is no movement at all, it is 4 again. And as we mentioned, if there is amputation, there is any joint problem, the patient can even try to hold his leg, this would be counted as UN, which is untestable again. So disregarding the motor, we are gonna test it for or assess it for both the leg and the arm. Now, there is another thing which is a 7th variable, which is the limb ataxia. Here, we are going to assess the coordination. We want to know, like, by assessing the coordination or the limb ataxia, we want to know, is this weakness coming from a real weakness, or is it coming just from the uncoordination? That's why we are going to do this. Another thing, we are assessing the coordination or the limb ataxia using 2 tests, which are the nose finger test and nose finger test and heel shin test. And you are gonna do it for the both side, like for the right and the left side. And another thing, you are gonna look if there is uncoordination, if there is any clumsiness, and you are gonna give your score based on that. So if there is no clumsiness at all in the both sides, is 0. If there is clumsy, like one limb is clumsy, this is 1. If the both limbs in both sides are clumsy, this is gonna be 2. Again, if there is amputation, the patient can't do this test, then immediately it's gonna be UN, which is untestable, but we will never put a score randomly without doing the full assessment. This regarding the limb ataxia. Another thing I wanna just repeat, like in the NIHSS, the lower score is the better. Like the lower is the better always. So again, we are gonna the 8th variable is the sensory, and we are assessing the sensation for the patient. So for the sensory, we are gonna compare the both sides, the one side to another, and usually we are bringing like a cotton tip, and we are just break that cotton tip applicator. Like we are gonna bring a very like a little long cotton tip applicator, and we are gonna just break it, and we are use the side that there is no cotton in it, and we are using it directly on a bare skin. It shouldn't be covered by anything. And we said the main thing that we need to compare the both sides together. We are not just dealing on one side. Okay. Another thing, we are not just focusing on one area. We need to look at the sensation in all over the body. That's why we need to check the sensory level or the sensory function in the cheeks. It will represent the face, in the forearm, in the thighs, and in the shins. All this, we are gonna do the sensory test for them. Okay, while comparing the one side to another through the test. Okay, so if we find that there is no sensory loss, the both sides, they are normal, and the sensation is the same in the both sides, and this is gonna be 0. But if there is one side is dollars and the other side is going to be 1. But why, if there is no sensation at all at one of the sides, this is going to be 2, which represent severe or total sensory loss. Okay. So now let's come to the language. So once we say language, this means that we are gonna assess the aphasia. And we know that the aphasia has 2 types, either to be expressive aphasia or to be receptive aphasia. What is expressive aphasia? Expressive aphasia is partial or complete loss of the ability to produce language. Which language? Spoken, manual, written. Another thing, usually the comprehension in the expressive aphasia remains intact. While in the receptive aphasia, there is a difficulty in understanding written or spoken language, while you will find also they are able to produce language. So here, mainly in the receptive aphasia, it is receptive. That's why you will find the reception, the comprehension is the main issue, unlike in the expressive aphasia. So for the aphasia, the first thing, if the patient speak, usually you will bring some kind of a paper. There is few stuff like they are drawn in that paper, and we'll ask the patient, what do you see? I will try to like look at his comprehension. Can he understand your questions? Can he understand what he see in this specific paper? So if there is no problem with his speech, like speaking correct, full sentence, this is going to be 0. But if there is a wrong or incomplete sentence, but still he got the message across, you understand that the patient is already understood what you ask him about, then this is going to be 1. Okay, so if you will find that there is any problem with like severe aphasia, like the patient, there is a problem in communication, there is a problem in the there is like a very clear problem in his speech, this is going to be 2. It's going to be severe aphasia, but still he's trying to talk. While if he can't talk at all, like there is a global aphasia, he is completely mute. This is gonna be 3. His score is gonna be 3 for this for the mute. Dysarthria. Dysarthria is different than the aphasia. That's why we need to assess it differently or separately. That's why dysarthria mainly regarding the definitions, it is dysfunction of speech articulation. Okay, the main problem here is there is a motor weakness of the speech generating muscles of the tongue, lips, or the face. That's why there is a problem with the speech articulation. So we will find that if the patient is speak clearly, no slurring, usually whenever you are finding there is a slurred speech, this immediately need you to go and assess the dysarthria. So for score 0, you will find that the patient speaks clearly, no slurring at all, while for score 1, you will find that the patient speaks with a slighter slur, but can still understand. This is a score 1. While for score 2, you will find it is slurred and you can understand, or even the patient is mute. So for mute here, we are giving him the same score as severe dysarthria or the patient who is unintelligible or who you can't understand him. Again, if the patient, there is any problem that you can't, like the patient is intubated, you can't assess him, you can't give him any score, you will write UN, which is untestable. Okay, so for the extinction and inattention, here you will find that you are looking at the neglect. Mainly, you are looking here at the neglect. We are using this to see like if there is a neglect at one side comparatively to the other side or not. Another thing, while we are looking at the neglect, it's not only motor, it could be motor and it could be visual at the same time. Okay, so this is the extinction and inattention variable. So if you can find that the patient, so this means that you are going to check the sensation and you are going to check the visual field and the visual sensation in both sides together at the same time, and you can move or alternate between the both sides simultaneously in order to assess them. So if you find that the patient can feel and can see both sides together, it's a score 0. Here, like this means there is no neglect, there is no inattention at all. But if you find that the patient does not see or feel one side of the body when tested together, then this means that it's going to be score 1. Okay, so for score 2, you will find that the patient can see and can feel one side of the body when tested together. Okay, this here you can see that this patient has profound hemi-neglect or profound neglect in score 2. So sometimes regarding the neglect thing, you will find the patient has both of them together, like not only visual or sensory, you will find the patient has a sensory visual neglect. And in this case, in this case, you will find that usually the patient is trying to get out of the bed and pushing his body away, like out of the bed. He is feeling that, like there is incorrect feeling that there is something in the bed next to him. This is in case of the visual, sensory visual neglect. So whenever you come and you want to do the test, you will find the patient is trying to push his body away and out of the bed. Okay. So usually this is the, like here we are putting the score for everything, and the scoring is range from 0 to 42. Also, we need to remember the lower is the better, like the lowest is the best. The highest means there is a severe neurological deficit. Another thing, the test is not this NIHSS is not the test that will determine the dysfunction or the deficit to the patient, because like the deficit will be determined by the physician or the provider who is gonna treat the patient. Because like if we see that the patient with one score of NIHSS and this one is coming only from the motor, like from the motor arm, and he is using his arm, like he's artist, he's a truck driver. He need to use his arm for his life. This means that this is gonna lead to a major deficit, and it will be very devastating to the patient comparatively to the others with the higher scores. That's why the NIHSS is not the only score that will tell us about the deficit, but it still will help in many ways. Usually you will find it we are doing it at the beginning and like in the admission, and also while you will find it in the progress notes, like while you are following up with the patient, and also at discharge. And why it is important? It is important because like if the patient came at the beginning with a score, let's say 8, and once you discharge him, you did thrombectomy to him, you give the patient TPA, and at the discharge, you found his NIHS score is just decreased profoundly. This means that the patient is improving. That's why. So we are using it to follow up with the patient, to look at the improvement based on the medication and based on the care for the patient. Another thing, we are using it like with other skills, such as modified ranking scale, such as the GCS, Glasgow Coma Scales as well. As Nadine mentioned, the most important thing in the NIHS is you shouldn't coach the patient. You shouldn't coach the patient. Another thing, the first response for the patient should be taken. You are not like, if the patient couldn't move his arm at the beginning and you gave him the score, but he could move it later on while you are doing the test, you are not going to go back and change your score for the motor arm. The another thing. Also, you will find that the score should reflect the patient true response, not the thing that you are telling the patient about, or your judgment, your clinical judgment. So these are the score. And this, if you look here at the screen, you will find these are some pics which are provided with the NIH people, which will usually the provider or the stroke nurse or the doctor using to ask the patient, okay, what do you see, to check his aphasia. And also, if you look here, these are some words that you ask the patient to repeat it after you in order to check the slurred speech, to check the dysarthria. So all these are provided in the NIH. And also we brought actually this file from the NIH website. And that's all for the NIHSS. If you have any question, you can go ahead. And thank you very much.
Thank you very much, Dr. Nadine and Dr. Riham, for nice presentation.
Thank you, Dr. Nadine and Dr. Nidhal, sorry, for the great presentation. Very thorough, put together, and to the point. Thank you for walking us through this powerful tool, the NIH stroke scale. And I believe understanding of this accurate use and, you know, the understanding of the accurate use of it and interpretation will help us providing better patient care and assessing the stroke severity and prognosis. So improving the patient outcomes. This session reinforced the importance of this tool, and I hope it provide all of us with more confidence in applying it whenever needed. Let's open the floor for questions. All right, so if you guys have any questions, feel free to share it in the chat box where the presenters can see them and address them. Now let's move to the next topic.
Now we are going with Dr. Syeda in the third agenda about how to make a scatter plateau with the trend line in Excel. Dr. Syeda, are you ready?
Yes. Hello. My name is Syeda Asna. I will be presenting how to make a scatter plot in an Excel sheet. So I will share my screen now. So can you see my screen now?
Yeah, it's clear. Go ahead.
Okay. Firstly, regarding the scatter plot in Excel sheet, it's simplify the data that we are seeing. So if you are seeing here, I have just simple data about the waist circumference and hip circumference for many patients, okay? So if I show you this graph, and just put in mind that in the real data for research, there will be a lot of data. Sometimes it reaches like hundreds of numerical data. So it's that using a scatter plot will simplify the relation between two variables or two numerical variables. So if I show you the second sheet in here, so it's more simplified. It's the same data, but in here I use the scatter plot to simplify, to know the relationship between the BMI, between the waist circumference and hip circumference. So here it's give you a more clear idea about the relationship between those variables. So it make it easier. So we're gonna go through how to simply make the scatter plot in Excel sheet, which help a lot in research. So here I have data. So it's a numerical waist circumference in centimeters and hip circumference in centimeters as well. So all what you have to do that make sure that the variables on the left will be an x-axis and the right will be on the left axis. So just make sure before you go ahead that the x-axis will be on the right column and the left axis, then the left column, sorry, and the y-axis will be on the right column. So then I choose what data that I want to use the scatter plot on it. So then go to insert, and simply here we have multiple charts that we can choose from. Here come to the scatter plot. So that the simple one is scatter plot, and then we have scatter plot with smooth lines, with markers and many variables. So I will show you how to use it in a simple scatter plot. So here it is, okay? Then you can change the title as well. In here, you can type any title you want, like here. Okay, waist circumference, hip circumference, let's say like that, okay? Then you can adjust it, you can adjust the borders by drag the arrow and moving it, expanding the picture or the scatter plot. And then also we can do a cool things about it. It's you can when you go to design, you can see here you can change the line, the color. Like I can change the colors of the plot itself, okay? Like for example, let's use this one. Okay, then you can change the style itself and design of the scatter plot, whatever suits you and you find it's very attractive. And then we can change the background as well. Then if you want to save it, just click, have a right click on it, then copy it or paste it, and then you can save it whenever in any sheet that you want, okay? So it's very simple to use the scatter plot, and it gives you just a simplified idea about the relation between two variables in a very simple way. That's why it's used in research. So here you can move it to see how to compare it with your original data. So seeing the two data in here, you can see this one is very easy to interpret. So if you can see here, the more waist circumference we have is the more hip circumference we have. So this can tell you that the relationship is like when we have increased waist circumference, it's spontaneously lead to increase in hip circumference in these data. I'm not talking about reality or something, but it's give you just like a rough idea about how relationship between the two variables, okay? So it's, of course, it's giving you the relationship between the two variables, but not the causality as the standard rule in research, okay? So yes, that's everything about scatter plot. It's very easy, and making the research data is more understandable. So if you have any question, we'll be happy to answer it.
Thank you, Dr. Syeda, for nice presentation and great job.
Thank you. I will be sharing my screen. So if anyone have any question, just drop it in the chat box and I will be delighted to answer it.
Thank you, Dr. Syeda, for this great presentation. This skill is very important and useful in analyzing data and visualizing trends. And mastering it will help us make more informed decisions based on the insights that we uncover through them. So thank you so much for sharing it. So do you have any questions or comments for Dr. Syeda? All right. Again, if you guys have any questions, feel free to put them in the chat box. Now we can move to the next topic.
Okay, and the next topic is aldosterone drug. The next topic with Dr. Mohamed about aldosterone dysregulation and its role in the primary hypertension. Are you ready, Dr. Mohamed?
Yes, thank you for the opportunity. Just I will share my screen. Okay, thank you for the opportunity. You have me, Dr. Nadir, and some moderator, Dr. Huyam and Dr. Namariq. Today our speaking, me and Dr. Ahmed Usman, will be about the aldosterone dysregulation and its role in the primary hypertension. As we know, from the American Heart Association, there is almost half of adult U.S. population have hypertension. 90 some plus percent of those population have primary hypertension as the diagnosis. Usually we just put it as primary hypertension. We didn't know what the cause this years before, it's about that there is vascular stiffness, but still we didn't know what the cause of the vascular stiffness. Also, unfortunately, the U.S. population now also suffering from obesity. So from 2021 to 2023, there is almost 40.3% have obesity. There is now speaking about the cause of the primary hypertension is due to aldosterone dysregulation. Usually it's aldosterone and it's part of the renin-angiotensin-aldosterone system. That system is discovered to control fluid volume in the blood, electrolyte balance, and regulate blood pressure since maybe 1960, 1970. But the complexity of the system still didn't understood very well. As we know, the renin-angiotensin-aldosterone system is ended with aldosterone. So the system is started usually it should be salvaging system like when we exposed to decrease blood pressure, to hyperkalemia, or to decrease blood flow to the kidney. This is the main stimulants to the renin-angiotensin aldosterone system. So it should be like the result usually it will be like increase in aldosterone level. And this increase should be like just to help increase the blood pressure, and then the aldosterone go to reset for the pre-stimulus status. So usually the kidney release renin when we have like decreased blood pressure, when we have decreased blood volume, or when we have sympathetic nervous system activation. That renin will convert the angiotensin that is circulating in our circulation to angiotensin 1. When then it's converted to angiotensin 2 by the angiotensin converting enzyme that is coming from the lung. The angiotensin 2 is potent vasoconstrictor that increase blood pressure through increasing the peripheral resistance. Also, angiotensin 2 reach the adrenal gland and allow synthesis of aldosterone through the increase the activity of the messenger RNA for in the zona glomerulosa to produce aldosterone. Aldosterone usually the messenger RNA that is aldosterone synthetase enzyme that making the aldosterone. The aldosterone synthetase enzyme, it have this like 93% structural similarity with 11B hydroxylase, which is produce cortisol. That what the challenge for scientists for years to find drugs that inhibit the aldosterone synthase without inhibiting the cortisol or affect the cortisol production. So this is like a visual summary for what I said. We see here like all the integral main organ in our system is involved in the RAS system. So like the liver produce angiotensin. Then when we have stimuli, usually on the juxtaglomerular system, like decrease our sodium or volume, or increase potassium to the kidney, then it will produce renin. The renin then converts angiotensin to angiotensin 1, and then the lung already produce angiotensin converting enzyme to convert the angiotensin 1 to angiotensin 2. Angiotensin 2 works through to the vessel by making vasoconstriction of arterial system, and also affects the adrenal gland, and it will take like hours to produce aldosterone. Aldosterone usually work in the distal collecting tubules to reabsorb sodium and water. Also, it help with absorbing some of the bicarb. So usually the main end of the RAS system, it's the aldosterone and antidiuretics hormone close the feedback loop of the RAS pathway by causing the kidney to reabsorb sodium and fluid, promoting potassium excretion in the urine, and adjusting the pH balance. The main thing here, like most of the aldosterone is considered like it's potassium control in our body. So when we inhibit aldosterone, usually the main side effect of that, like we will have hyperkalemia. That's why also this is like not favorable for us like to prescribe aldosterone receptor blocker because of the risk of the hyperkalemia and the complication of the hyperkalemia. Other hormone, aldosterone also like recently they discovered is not like just stimulate to secreted by RAS system. Also, they found like estrogen is involved in secretion of aldosterone. Thyroid hormone is involved in like increasing the aldosterone secretion. And in obese patient, usually with adipose tissue, leptin, also it's involved in increasing the aldosterone production. There is a number of conditions well known that cause inappropriately elevated level of aldosterone. One of them is primary aldosteronism, also known as Cons syndrome, which is when the adrenal gland produces too much aldosterone. Usually, it's caused by aldosterone by adrenal adenomas or adrenal hyperplasia or familial hyperaldosteronism type 1. There is secondary aldosteronism, that's the one we usually consider, which can occur if blood flow to the kidney is reduced, either due to obstructive renal artery disease. This, by the way, is the most common cause of the secondary hypertension, or a condition like heart failure, which will then inappropriately trigger the RAS pathway system. In high sodium concentration, elevated aldosterone level can cause hypertension, high blood pressure, a risk factor for cardiovascular disease and cardiorenal complications that are independent of the effect on the blood pressure. I usually as I tell, like aldosterone is salvage hormone should be to increase sodium in our system, and with the sodium will absorb water. So usually it will be okay like if we have low our normal sodium intake. But unfortunately now we are most of us like taking double the amount of the sodium intake per day we should take it. So instead of taking 2,000 milligram per day, we are almost taking 4,310 mean per day. In other words, for the same blood pressure level, patient with excess aldosterone have higher risk of adverse cardiorenal outcomes than patient without elevation of the aldosterone or elevated aldosterone. That is appropriate for their sodium status. Studies indicate that there is high prevalence of aldosteronism among patients with hypertension, particularly on those who have more severe or resistant hypertension. And in this, in the 119.9 million who have hypertension, in US they found like only 25% of them they have controlled hypertension. So like 75% of the people they didn't have controlled hypertension, and that's why like they start to consider like to seek the cause of the primary hypertension and try to control it. They found unfortunately, this is not like published now, but like a lot of uh, uh, clinical trials now gone through the pharmaceutical companies. They did like internal review or studies for them before they go to produce trials and medication. They found almost around 65 something of patient with primary aldosteronism. They have kind of aldosterone dysregulation. So like they have a higher aldosterone that is not like going with their it should be like reverse. So instead, like you have higher tension than normal, you should have low concentration of aldosterone. But they found almost 65% of the population either they have normal or increased aldosterone level. Aldosterone dysregulation occur as gradual, continuous process rather than like on and off switch from normal function to dysregulation. When unappropriately regulated, the normal feedback loop breakdowns so that even when running levels are low, in the presence of the triggers such as increased sodium concentration or aldosterone still remain high, uh, leading to hypertension and adverse cardiorenal outcomes. The causes of this feedback loop breakdown is unknown. However, risk factor may include excessive salt consumption, diabetes, sleep apnea, adrenal adenoma, the presence of aldosterone producing micronodules, and obesity. All conditions in which blood pressure regulation is disrupted, for example, like adipose tissue release leptin, which bypass the RAS pathway to stimulate the aldosterone secretion. I will leave the panel now for my colleague, Dr. Ahmed Osman, to carry on.
Hello, everybody. Do you hear me, Dr. Mohammed?
Yes, Dr. Ahmed.
Thank you. I'll be talking about the roles of aldosterone in disease pathophysiology. Beyond fluid and pH regulation, aldosterone also promotes fibrosis by stimulating collagen production and deposition, causing scar tissue formation in the heart and blood vessels, and also remodeling of some organs and impairing their function. Moreover, aldosterone can induce inflammation and oxidative stress, further contributing to damage in cardiovascular tissues. This indicates that beyond maintaining blood pH and electrolyte levels, aldosterone may also play a role in cardiovascular remodeling and renal function. There is also a newly discovered membrane receptor, the G protein coupled estrogen receptor that binds to aldosterone and can mediate vasoconstriction and further sodium and water retention and other risk factors of adverse health, such as cardiovascular endothelial dysfunction, apoptosis, and inflammation. Can you do the next slide, Dr. Mohammed?
Yes.
An increasing body of evidence links aldosterone dysregulation and mineralocorticoid receptor hyperactivation to cardiovascular disorders such as hypertension, metabolic syndrome, coronary artery disease, chronic kidney disease, and congestive heart failure. Increased aldosterone levels can also lead to off-target effects in endothelium. For example, elevated aldosterone levels are correlated with increased inflammatory markers, stimulating fibrosis in the kidney, heart, and other vessels. Aldosterone can also make vessels less reactive to nitric oxide, which can lead to vascular dysfunction. Altogether, this inflammatory ecosystem further drives organ damage beyond hypertension alone, with the aldosterone-induced increased blood pressure leading to increased cardiorenal risk and the subsequent cardiorenal dysfunction, resulting in end organ damage independent of hypertension. Here we're going to be talking about the pathway for therapeutic targets. The classical view for renin, angiotensin, aldosterone pathway and aldosterone is that of hormonal feedback loop responsible primarily for sodium and water hemostasis. Our understanding for this loop has, however, greatly expanded, demonstrating that roles of renin, aldosterone, and their associated substrates and ligands in human physiology may be more complex and far-reaching than originally thought. The current therapeutic options for treating hypertension consist mainly of ARBs, angiotensin receptor blockers, or ACE, angiotensin converting enzymes, inhibitors, and mineralocorticoids receptor antagonists, MRAs. ACE and ARBs cannot inhibit the hypersecretion of aldosterone, and their chronic use will lead to failure of aldosterone suppression overall, which also known as aldosterone escape. Next slide, please, Dr. Mohammed. Results from the Pathway 2 trial demonstrated that patients with aldosterone dysregulation see less of an effect receiving certain ARBs when compared to MRA. These results suggest that a significant portion, 25% or more, of patients with hypertension would benefit from earlier treatment with a therapy that directly targets aldosterone. Though MRAs are effective in blocking aldosterone action, but they still have an undesirable off-target anti-androgenic effects. Aldosterone synthase inhibition has been hypothesized as an alternative therapeutic option that is selective enough to prevent the off-target effects seen with MRAs. Suppressing aldosterone hypersecretion does not only play a role in preventing hypertension, but also could prevent organ remodeling in the heart or kidney, and also the stiffness in the blood vessels. Appreciating and further investigating the complex roles of renin, angiotensin, aldosterone system pathway in the body is vital for both scientific research and the development of therapeutic interventions for a spectrum of cardiorenal diseases. Such of these clinical trials will be concluding this presentation with is we have here AstraZeneca Zenith trial, which is a phase 3 study to investigate the efficacy and safety of baxdrostat in combination with dapagliflozin on chronic kidney disease progression in participants with CKD and hypertension. Also, we have another study, Mineralis, which is the efficacy and safety of lorundrostat in addition to sodium glucose cotransporter inhibitors 2, SGL2I, in subjects with hypertension and chronic kidney disease with albuminuria. If you have any questions, you can go ahead now with your question, or you can mention that in the chat box.
So, first, these studies like baxdrostat and lorundrostat are aldosterone synthase inhibitors, and they added with so the cause that they added with sodium glucose cotransportation inhibitors because now the sodium glucose cotransporter inhibitors are considered like as standard of care for patients with chronic kidney disease.
You have any question? Well, thank you, Dr. Nader, for this great opportunity. And thank you, Dr. Mohammed, for covering this interesting topic.
Thank you very much for nice presentation. And great job.
Thank you.
Thank you for the great presentation. And this is a very important topic because it can help with understanding how to manage different condition like hypertension, diabetes, and the management of them and how different medication works, like diuretics and antihypertensives. So thank you so much. And we're gonna move to the last part of our meeting today, which is the mock interview. And as we approach the interview season, with many of our fellows preparing to tackle the residency interviews, I think today's mock interview session comes in the perfect time. This will not only help us or help with refining and practicing the interview skills, but also in turning the attention for small points that it might be went unnoticed. So the format today will mirror the real interview scenario, followed by detailed feedback to help strengthening the responses and the presentation. And this is very invaluable to building confidence and ensuring that you're fully prepared for the important interview ahead. Now let's get started. Dr. Huyam can present
Yeah.
the applicants. So we're gonna have Dr. Mohamed. We're gonna have
Dr. Riham and Dr. Zainab.
okay. And Dr. Mohamed Sati will be serving as the program director. So I hope you guys are ready.
Yes, I'm ready.
All
Hello,
right,
everyone.
so let's just give some time for Dr. Mohamed to join and we can get started. So Dr. Mohammed is trying to log in, but he's facing some technical issues. Meanwhile, we can get started. I can try to be the program director until Dr. Mohammed join us. So Dr. Riham, are you ready?
Yes, I'm ready.
Alrighty. So we're gonna start, okay?
Is the video open? Can you see me?
Can you try to open your camera again? Now, yes, we see you. Right.
Okay, good.
Perfect. All right. Thank you, Dr. Riham, for being here today. And can you please tell us a little bit about yourself?
Okay, thank you for having me. This is a great opportunity for me. My name is Riham. I was born in Sudan in a loving family of 8. I have a huge family. And I was raised in multiple countries because during my childhood, we traveled a lot due to my father's job. That made me really social, really adaptable to different settings and able to communicate with different people. And fast forward to medical school, I balanced my academics with a lot of extracurricular activities. I participated in community outreach programs. I did a lot of volunteer work with non-governmental organizations. So I think that really helped with my teamwork skills and my leadership skills. Additionally, in the 5th grade of my medical school, I was an exchange student to Brazil. I participated in a research exchange program. So that was a really great experience for me. After that, after graduation, I did my internship in rural Sudan, rural Eastern Sudan. It was a very hectic environment. We treated a lot of internally displaced persons, but I learned a lot from it, and I think I was able to improve my clinical skills and my clinical knowledge. Other than medicine, I really, really enjoy traveling. I've traveled to a lot of places inside my home country, and I wish to travel to even more places in the future. So that's it.
That's great. And now can you tell us about your biggest weakness?
Okay, so my biggest weakness, this is something I struggled with in the beginning of medical school, was that I had a hard time accepting criticism. Because I think that I really work hard in everything that I do. I put my heart and my soul in it. So whenever I was faced with criticism, I felt a little bit discouraged. But then I learned that criticism is an integral part of medicine, and that feedback is important for me to grow and develop and move forward. So I started taking this feedback into account. Whenever I received feedback, I asked for clarification. I asked for advice and how to improve myself. And from then forward, I found myself that I really develop and progress. So actually, right now, I seek feedback actively, and I really appreciate it. And I appreciate when someone takes their time to to just help me.
That's awesome. And can you tell us why you chose internal medicine as a
Okay.
specialty?
Okay. So because during my childhood I traveled a lot, I came to really appreciate human connections. And in internal medicine, I get to have long-term relationships with my patients, which is something that it really fulfills me, and it's something that I really appreciate. So I get to fulfill my need for human connection. And at the same time, while growing up, I was a huge nerd. I love reading. I love learning new things. So internal medicine, it fulfills this intellectual curiosity because it encompasses a variety of cases, a lot of complex cases. So it's exciting for me. And another thing is that internal medicine, it offers me a lot of options. I can specialize in cardiology, GI, anything, and each subspecialty is a world on its own. So yeah, I enjoy the versatility and freedom in internal medicine.
That's awesome. Thank you, Dr. Riham, for being here today, and wish you good of luck.
Thank you too. Thank you very much.
Thank you. All right, so you all have watched Dr. Huyam performance, and please feel free to share comments and feedbacks that can help her perform better. So please go ahead. I'll start. You did a great job, and it was really impressive, and
Thank you.
it's very obvious that you worked hard preparing for it. I'm gonna start commenting about the setting.
Okay.
Yeah, so the lighting is good. But it's always better to have something in the background, like something that can give positive energy, or something that can give a hint about your personality. And that can also help you breaking the ice in the beginning of interviews, because they might ask you about that, background. Yeah. So just try to choose something that you can talk about and put it on the background. Yeah. And I think also it would be better if you can go just a little bit back. So yeah, like they can see all of your body language, and yeah. Anyone
thank you.
would like to comment on the performance?
Hello, Dr. Riham. Actually, you
Hello.
did it. Your language were excellent. Your articulation were amazing, but it looks like you need like to practice a little bit on on mirror just to show up that you're a little bit nervous. I know it's your first time, you're kind of nervous, but I think with just more practice, like looking at yourself to a mirror, talking to anyone, you could, break that. But I'm really impressed about your language, your articulation, your accent. This is amazing.
Thank you very much. Thank you, doctor.
I agree with Dr. Riham, and I believe this will get better with the practicing. And
Yeah.
I also have a little bit of comment about blinking. I feel like you blink a lot, so this might
Because
be
I'm
something
nervous.
come spontaneous.
Yeah,
But
it's
yeah.
kind of like just a stress but you just need to overcome that with like more practice. But everything else is amazing.
Right.
Okay. Yes, I'll practice more.
Thank you, Dr. Samar, for your feedback. Any other feedback, guys, or comment? Okay. All right. So thank you, Dr. Riham,
Thank
for
you for your too.
participating. I know it's not easy taking the the opportunity and start practicing. So this is by itself, it represents your personality, and yeah, so thank you.
You're welcome. Yes, I wanted to participate just to, get used to it and get used to talking in front of a lot of people.
Of course, it helps a lot, and this is a huge opportunity. So I would like to encourage all of the fellows to participate, because we don't find this all the time. So whenever you get the chance, please take it and make use of it. And I wish you best of luck for in residency.
Thank you, you too.
Thank you.
Thank you very much. Thank you, everyone.
We have Dr. Zainab next, I believe.
Yeah, but she sent a message. She wants 2 minutes
No
to
problem.
be ready.
And
Yeah.
no problem. And Dr. Mohamed will be the program director. And let me take the opportunity and thank Dr. Mohamed for accepting our request at the last moment because it had to be Dr. Rufaida, but she had an emergency and she had last moment apology. So Dr. Mohamed was open to accept the request. And so thank you so much for this.
Hello, Dr.
Um,
Naim. That's, I hope a good season for all of you and best luck. Yeah.
Thank you. Thank you. So Dr. Mohammed, you can prepare your camera and while Dr. Zainab is going to join us. Is Dr. Zainab trying to log in? Right. I think Dr. Zainab is experiencing some technical issues and unable to join us.
Yeah, I think that.
Yeah.
He sent
All
message.
right. No problem. Is there anyone else would like to take the opportunity and serve as an applicant? All right. If no one is ready today, no problem. The upcoming weeks, there are going to be more mock interviews. And yeah,
Sorry,
so
Dr.
you guys,
Namariq.
yes.
She sent me she is ready.
All right, so go ahead, Dr. Zainab.
Dr. Zainab. Dr. Zainab.
Perfect. Dr. Zainab, we see you, but we don't hear you. No, actually, we don't hear you, but we're able to see you. No problem, Dr. Zainab. Yes, I agree, Dr. Zainab. Yeah, just let's take it as a lesson. So you need to check your computers and your cameras beforehand. At least the day before your presentation or your mock interview. You don't want to experience these technical issues during the interviews and ruin out your interview. All right. So I think
I think I got it. I logged in using a different computer. Can you hear me?
we do
Can
hear
you hear
you.
me?
There is an echo though.
There is? Is it something we can work with?
Yeah, I think it's better now.
Okay.
Dr. Mohamed.
Hello, Dr.
You can open your
Hello. I'm sorry, did you say there's an echo?
Yeah, there's an echo. Clearly here. I don't know why.
I'm sorry, how bad is it? Should we reschedule for next week, or is it something you think we can work through?
I think you can mute yourself while others are talking, and then unmute yourself whenever you want to talk. Yeah? I think it's gonna be better.
Yes, I can do that.
So what shall she will do? She will mute herself and I will ask her the question and then she will answer.
Yeah, she's just gonna mute herself while you're talking, and then when she's would like to start to talk, she's gonna unmute herself. So yeah,
Okay.
you just go ahead and start, Dr. Mohamed.
Okay. Hello, Dr. Zainab. We are very glad to have you today. We wish you a good cycle in this season and to match in the program that you want. So, Dr. Zainab, could you tell us about your regular day? What are you doing nowadays?
Hello, thank you so much for having me. I'm very happy to be interviewing. Is it the echo?
Yeah, I can hear you clearly.
I sincerely apologize. I've never had this difficulty before. Literally the first time.
Okay.
Um, I would like this to be a better experience. Would it be possible to reschedule, please? Maybe next week, inshallah, if that's possible.
Yeah, you can. We can hear you. Go ahead.
Okay, all right. Well, thank you very much for having me. I'm very happy to be interviewing with you and to get to know more about your program. My typical day starts at 4 a.m. I'm an early riser, and that's important because I have a young daughter that I take care of. My day consists of doing chores and helping my family, and also preparing for my interviews this season. I'm also somebody that helps out my family a lot. I volunteer on a typical Saturday. I go to the free clinic to help out, and I also check in with my family in Nigeria to make sure that they're doing okay frequently.
Barely hear you. But no problem. I think the other applicants hear you. Anyone here can hear Dr. Zainab? Really, I have a difficult to hear Dr. Zainab. But if one, yeah, the voice is not clear. Yeah. We cannot give you a feedback for something that we couldn't hear. Sorry for that.
No, I understand. But I don't want to keep wasting everybody's time. If it's possible, I'll just go next week, inshallah, and I will make sure that my audio is working before then.
Okay, no problem.
Thank you. Everybody.
Okay. So just not to waste our time today, we can have a practice to lessons, and I can introduce Dr. Namariq Naim as an applicant for our program. Just for the sake of practice, could you be an applicant for us, Dr. Namariq?
All right.
Okay.
I'm not ready, but
no problem. Just for the sake of practice and to make these sessions more useful. Okay.
no problem.
Okay. Thank you. Dr. Namariq Naim, we are very glad to have you today. And you have a good resume, and you see that you are graduate from 2015, I think. A little gap till the applications. Could you tell us about yourself firstly and why you applied to after all this time after graduation?
Sure. First of all, thank you for having me and for giving me the opportunity to meet with you today. It's a true honor for me. My name is Namariq Al-Naim. I'm an American citizen, originally from Sudan. I am a blessed and proud mother of two beautiful boys, Ali and Ahmed, who are my soul and my drive for continuous success, both personally and professionally. I was born and spent my formative years in Saudi Arabia, where my father worked as a physician. We later moved to Sudan, where we originally from, and I joined medical school at Ahmad University for Women, one of the leading and biggest institution for women education and empowerment in Africa. During medical school, my passion for medicine grew day by day, making me outstand academically, graduating one of the top 10 of my class and earning the School of Medicine Award for the best research upon graduation. Now, volunteering has always been close to my heart. I worked with various organizations, serving and helping the community on multiple levels. After graduation, I completed my internship, rotating in different specialties. And that when I realized that internal medicine was my calling, which drove me to start training there. But later, because I had to join my husband in the US, my kids and I moved to the US, where I started my US career journey. Since then, I successfully completed my steps, including step 3. And I was fortunate to have opportunity to do some hands-on experiences in the US, which helped me engage more and understand the health system in the US. I am currently a research fellow at Geriatric Research Fellowship, which helped me tremendously in enhancing and improving my research skills. Outside of medicine, I love to spend quality time with my family, doing fun activities. And I also consider myself someone who sees beauty in everything, which inspires me to designing dresses, creating decorations, especially for events, and styling hair for kids, making out-of-the-box hairstyles. I'm truly excited about the possibility of joining your residency program, where I can combine my passion for internal medicine with my commitment to community service and education.
Okay, sounds good. You are one of the great applicants that I have seen this season. Wish you a good luck. So, Dr. Namariq and Naeem, everyone have a weakness, and could you tell us about your weakness?
All right. When thinking about weaknesses, I would say one of my weaknesses is sometimes I find myself focusing too much in details. While attention to details can be beneficial, sometimes it's a challenge when I'm facing tight deadlines. For example, during my first year of medical school, I was assigned for my first presentation. And I remember that day when I gave the presentation, I received feedbacks from my mentors and colleagues telling me that they felt lost through the details and the crowded slides. That experience turned my attention that I need to reassess my approach. I learned to prioritize the big picture and the main objectives first, breaking down the task into smaller ones and allocating specific time frame for each task. Now, over time, these strategies has helped me tremendously in improving my performance, but also helped me in increasing my adaptability. Now I find myself someone who's self-aware about when I start to dig in deep into details, which allows me to turn my attention back to the main objective. And I'm still committed to continually grow and improve in this area. And this experience has also make me realize and reinforced my deep belief that whatever weakness we have, we can improve it, overcome it, and even turn it into a strength with proactive efforts, readiness to change, and having a good self-awareness.
Okay, that's great. We wish you to improve yourself in all aspects of your life, personally and professionally. Thank you for your good and wonderful speak. We wish you a good luck in these seasons, and bye.
Thank you so much.
Okay. If anyone have feedback for Namariq.
That was a great introduction, Dr. Namariq. I actually felt like it's touching and at the same time reflect who you are personally and professionally. So it was really good, was really concise, into the point. So all your answers were good. So that was so inspiring, actually.
Yeah, I agree with
Thank you
you.
so much.
I agree with you, Dr. Syeda. It was amazing. I'm actually inspired all of us.
Yes. So wish
Thank
you
you,
good luck,
guys.
Namariq, and good luck for everyone.
Thank you, guys. Thank you. And I wish the best of luck through the season. It's a very like stressful time, but we're gonna go over it and we're gonna pass it, and hopefully we're gonna match at the end, all of us.
Inshallah.
Thank
Dr.
you. Thank
Namariq.
you. Sure. Go
Yeah, I
ahead.
just wanted to add that your presentation was so good. I literally felt that I was listening to an AI chatbot who was preparing for an interview. I mean, amazing. I think I'll definitely reach out to you when I'm preparing for interviews. It was amazing. Thank you so much.
Oh, thank you so much. Thank you. I really appreciate your comments.
I just have one comment, it's, as I told you, it was perfect.
Please.
But yeah, because I don't see your face and your expression, but yeah, I hope that you were smiling behind the camera when you're telling your story, especially in a personal aspect. That's all.
Yeah, I apologize for not opening the camera. I wasn't
That's okay.
prepared for
Yeah.
it. Dr. Mohamed just, put me on the spot, so I had to do it, without preparation. But yeah, maybe next time we'll open the the camera, and practice completely. Thank you so much. Thank you. Now I think as we reach this point, let's open up the floor for general discussion, questions, experience, exchange regarding the fellowship. And yeah, so go ahead, guys. If you have updates regarding projects, researches, please feel free to share it with us. All right.
Hello, everyone. I hope
Yes,
you can hear
hello.
me.
Yes, we do, Dr. Selma. Go ahead.
Hi, thank you all for this amazing session. My question is regarding linkers. When I'm preparing for my interview, I used to write my answers in a bullet point. But then when I try to say it in a conversation kind of manner, it gets really difficult to connect each and every idea with the other. So I'm asking if there is any tip that you can provide, or any other applicant or a resident who can provide us with a tip. Thank you.
Thank you. Dr. Renda, do you want to answer Dr. Selma's question?
I apologize. Yes, it is because I have update.
All right, sorry. Okay. So doctors, so let's take all the questions and then we can answer them in order. Or if anybody would like to answer Dr. Selma's question, please go ahead.
Hello. I think the thing is to do practice. Just keep practicing. Make interviews with friends, with other people. Write the question you are expecting them to ask you, and prepare your answers. Let your husband, your brothers ask you the questions, answer it. Just keep practicing.
I
That's
just
great.
have
Thank you.
one. Yeah, I have one addition in that, one advice. So yeah, I know I got your point that you are troubled with the transition from the bullet points that you have already, right? So if you mention the first bullet point and follow that with the example, as Dr. Namariq just said, So then the second point, it doesn't need to be like completely related to first. But for example, if you are talking about your strengths, so the first one may be something not related to the second one. So after you mention the first one, take your time, give an example, and then you can say, my second strength is, and then finally is. So it's not that a big deal, but the flow of the sentences and the flow of your speech in general should be like clear and concise and to the point. So that's my advice. I'm also on the same stage as you, but yeah, I believe that can help.
Thank you, Dr. Syeda. That's actually very helpful.
Thank you.
Yeah, I agree with Dr. Syeda that it's all about practice and just brainstorming first your mind, and then try to practice and not just with yourself. You start with practicing with yourself, but then with your colleagues. And I also encourage to have a mock interview with somebody who you don't know, and you don't know the question he's going to ask you, because that will make you prepare for the on the spot questions. Yeah, so that's also important. And if you find yourself somebody who feel more comfortable talking without just knowing the whole script or the whole story, then you can have just points in your mind, just in order, and you can just talk freely about it. But if you find yourself someone who get nervous and cannot just talk spontaneously, you can even just with practice, you're gonna learn that what to say and how to say it, and that will make you perform better.
All right. Thank you, Dr. Namariq. Thank you.
Thank you. Thank you, Dr. Salma. Dr. Renda, you can go ahead.
Hello, Dr. Namariq. Hello, everyone. My name is Randa Hassan. I'm graduated from Kordofan University in Sudan, and I applied for residency this season. First, I want to thank you, Dr. Nadir, for this great opportunity, and also thank him for the continued help and support. And before I update on our project, I want to take a moment to thank you, Dr. Amal and Dr. Mafaz, for their support and their invaluable advices throughout our project process. And I want to thank you, my dedicated team, for their collaboration, dedication, and their patience throughout our project, which is a mobile application to help diabetic patients to regulate their carbohydrate intake. And now we're almost done with our project, or at least our plan for this version. So I want to share it with you if I can.
Just go ahead, Dr. Randa. Dr. Randa? Okay, good.
Can you see my screen now?
Yes, we see your screen.
Very good. Okay, now I will share with you with the codular companion, which we use it to test our, and this by this codular companion you can see the real aspect of the project, and that what the user will see on the real application. So our project, we use codular to create our project, and it have two components. One, the user interface, and the other one is blocks. The user interface, that what we the user they can see on the real life, and the blocks, that what will make the interface component functioning, and that will be able to control our app. Now I will start with connecting our app with codular. Here, as you can see, we can scan the code. Just loading now. Our app name is Smart Diabetes Control, and the first screen which will appear for the user when open the app is a splash screen. This is splash screen. There's our name, our app name, Smart Diabetes Control. It takes a second and will open the login screen. As you see, the login screen, you have to fill the username and password. For the first time, the user will not have any account, so we have to create their account first. Press here, and when the created account screen open, we have the username, the password, confirm password, date of birth, and email. Let's move on this. I can just write my name. Let's see. And password just randomly 1, 2, 3, 4, 5. And I will confirm it. Okay. The date of birth, let's see, anything, 2000. Okay, and the email, I put my email here. And then I press create. And as you can see, your account was created successfully and return me to the login screen with my username and password. Here, if I change the password, like if I omit 5 and I try to log in, it gives me the password incorrect. If I change my name here and just like run and I try to connect, the username incorrect. So that the information now was kept, and I write my name and the username and password, then login. So it takes me to the main screen for our app. Okay, this Smart Diabetes Control, we have just a little bit description below. As you see, welcome to Smart Diabetes Control, a smart and simple tool designed to help diabetic patients take control of their health, easily track your carbohydrate intake, monitor blood glucose and other vital signs, and access valuable educational resources. With personalized insights and easy-to-use features, Smart Diabetes Control empower you to and make informed decisions for a healthier life. Just a brief description. So, yeah, as you see, line up the screen, I press, they give you the menu. my profile, diet, tracking list, educational topics, and notes. If I open my profile, to my profile screen where I can insert the name and date of birth. Let me check randomly, and the email address. So we have the average blood glucose if we want fasting, random, postprandial, prandial. Let's see, 110, and the hemoglobin A1C 6. Blood pressure, if I choose 120 and diastolic 70. On the BMI 24. Medication, I write anything like insulin, or whatever. And here's a pharmacy. You can write the address of the pharmacy, like CVS or something, whatever. And then to keep my information, I can press save, and you see your profile was saved successfully. Okay. If I want to share my information with doctor, with friend, with whatever, I press share, and I will be able to share with them. And lastly, we can get back the information. If I lost that, I can get back my information here. My name, my date of birth, my email. For my profile. Here. Then moving to the next one is the diet, and this is our main objective. Track the diet, we can help the user to plan his meal. So we can set the date, the time, and let's say it's breakfast. Okay. Then here we search for the nutrition the patient is looking for. If I say, let me see, we have an extensive list from US Department of Agriculture. They have the nutrition and their carbohydrate contents. So this is our list, and let's say he pick barley flour here, and as you see, it gives you the nutrition that choose barley flour or meal, and for 1 cup the carbohydrate is 110.29 grams, and by this the user can decide if he will take this meal or he want to change it according to his blood glucose levels. So also if this clients work with him or want to keep it as a favorite, you can press here and add it to your favorite. And this is your favorite, my favorite food. Like this, the date and the time where I choose that, and it is a breakfast, and it is barley flour or meal, and for 1 cup the carbohydrate is 110.29, and we'll keep this one on his favorite food. Okay, the next time, if you want to remember the last food he took, or that set it as his favorite, you can just press here and he will see that that his favorite food, and maybe he can take it again. Okay, that for the diet part, and move for back to our main screen, which get the tracking list. We set tracking list for glucose, blood pressure, heart rate, oxygen, temperature, weight, BMI, height, hemoglobin A1C, and also we set part for exercise, insulin, medication, and notes as well. If set the time now, the date, and let's say the glucose today it's fasting, so the user can insert what he's fasting now. It is or 200, okay, and he can save that. And the next time when he opens the app and want to compare the last reading of his glucose level, the reading today, he just can read here the previous glucose level, and he gets the date and time where he took it, the last one, the last reading, okay? And also for blood pressure, it's the same. For heart rate, the same. Oxygen, weight, BMI, hemoglobin A1C, insulin, and notes. Also on the notes, he can write whatever he wants. We set a heading to just mark the title of what you want to keep it. So like if you want to keep like let's see what he did for his exercise, you want to keep it, and at the body he can type what he did, like he did walking, walking like for 30 minutes or 30 minutes or so on, or he planned to do that at certain time, something at certain time, just whatever he wants, and just he save it, and the next time when he opens that open his note again, he just get my note, and as you can see it is already here kept, and he can know what he whatever he wants. Okay, we can go back and the educational topics. We set some educational topic to help the patients to know about their condition, how to control it, some information about the nutrition, about fitness, about the treatment and complications, about insulin resistance and follow-up. So here there is some question, important question to ask the doctor, and that will help the user when he meet his doctor, what he can ask him. So get that. And here between diabetes type 1 and diabetes type 2, there is information about that. And the same for nutrition, for fitness, treatment, insulin resistance, complication, and for follow-up. One, huge information. We hope that the user can benefit from educational and help them to take care of their health. And moving back, educational topic. The last one is just external note, the same like that in the tracking list, and just they insert whatever they want, just to give them more space. That all That's all what I want to share it about our app, and that's what we plan to did in this version. So far, we're almost done, and we'll move to the next step. We have also other features that we will work on it second version. That's all. Thank you so much, and your feedback and your advices would be appreciated. Thank you.
Thank you, Dr. Randa. This is an amazing job. I mean, this is impressive. Thank you for this great job for you and your team. I don't have any comment other than it's an amazing job. And I hope it's going to be beneficial I'm sure it's going to be beneficial for patients and doctors. Yeah.
We hope that. Thank you.
Yeah. Good job.
Inshallah.
All right, guys. Is there any more comment or feedback? All right. If not, I think we came to the end of this meeting. I'd like to thank Dr. Nadir for giving me this opportunity for mentoring this meeting today. And I would like to thank the Canary team for conducting an awesome meeting. Thank you all for being here today and for being patient until the end. And yeah, we'll see you next week, hopefully. Thank you all. Bye-bye.
Thank you so much, Dr. Namariq, and thank you all the presenters. Thank you all the team members, and thank you for the diabetes app demonstration. Thank you everyone for attending this program, and we'll see you next week. Assalamu alaikum. Thank you everyone. Thank you, Dr.
Alaikum
Namariq.
assalam. Thank you. Bye-bye.